I'm going to talk to you about this issue of co-infection, and I'm going to, first of all, I have no disclosures for those who see any interest. I'm going to be clear, and I'm going to emphasize a few very simple points about co-infection. I think you're probably, if you have any sort of clinical inclination, already aware that co-infection with these viruses is very common. I'll start with that and review briefly the medical importance of these, but really as a backdrop to setting up a way of thinking about them that helps us understand one of the most interesting new developments in the treatment of co-infection, and that is the issue of the consequence of treating one on the other infection. So that's why I call it collateral antiviral damage. That may not make any sense to you now, but hopefully in about 18 minutes it will. So first of all, these infections, of course, are common. It's not mysterious. It's because they're passed by similar ways from similar people, and that leads to the frequent occurrence of co-infection. When you take it from an HIV perspective and think about once someone's already acquired HIV from injection drug use, for example, the more transmissible hepatitis C infection is principally already there. And so if you look at injection drug users, nearly somewhere between 80 and 60 to 80% of those that have HIV also have hep C, for example. That the rates are lesser when you consider sexual routes of HIV transmission, once again just reflecting that rather obvious that HIV is more transmissible by sex and therefore more abundant in those populations than HCV. Hep B, very efficiently transmitted by both routes, but not always persistent, and so ends up with an interesting, very common co-infection if you look at having had Hep B in the past, as indicated by having that antibody to the core, just having been infected before. Just like Hep C, nearly all those that acquire HIV from drug use have had Hep B, and lesser amounts with those that acquired HIV from heterosexual or who have passed it between men. If you look at Hep B persistent infection, chronic infection, not just having acquired it before, but still having it at the time of the assessment, the prevalences are lower. And once again, it's right about 7 or 8% in the European and most of the large cohorts in the United States and in Europe. And interestingly, wide-ranging estimates from sub-Saharan Africa and Asia. In fact, this was one ACTG registration trial, so it's a bit selected, but these are HIV co-infected individuals starting on antiretroviral therapy, and you'll see that wide differences around the world in the prevalence of Hep B HIV co-infection. So all that just to say that there's a number of HIV infected people that also have one of these other viruses, and Scott said earlier today, and others as well, toxic EMB and the like. So co-infection is sort of the rule with an HIV infected individual. When you think about these interactions that occur, it's first of all very clear that if you have HIV compared to not having HIV, every single thing that's bad occurs more in the HIV infected person with Hep B or Hep C. So they have higher viral loads, they're first of all infected more often, they have more often chronically infected, they have higher viral loads once chronically infected, they have more cirrhosis, they get cirrhosis over fewer years, and then once they get cirrhosis, they die faster from it. So it's just everything that could be bad is worse if you also have co-infection. It used to be true that it was harder to treat them as well, but that's fortunately rapidly changing. Interestingly, the course of HIV and the response to antiretroviral therapy may also differ. There's a more mixed data on this point, but it may be that if you also have another chronic inflammatory condition such as hepatitis B or hepatitis C, that makes HIV worse, and even after adjusting for other factors, the CD4 increase after antiretroviral therapy lower. Even without HIV, so we're now just asking the question, what about Hep B and Hep C together? there's also interactions, and they're medically important in that, as you might expect, the two together have more liver disease than either, for example. It's also important, especially with what I'm about to talk about, to know that for a long time we've appreciated that there's a reciprocal interaction. When you have hepatitis B and you get a hep C, one of the viruses tends to dominate. One of them tends to be very easily detectable in the blood, whereas the other one's either suppressed or undetectable or lower than you'd expect amounts. And that's been evident in multiple different cohorts in Baltimore injection drug users, for example. If you're comparing someone with hepatitis B, with chronic hepatitis B, to someone without, you're 2.7 times more likely to have cleared the hepatitis C infection, so spontaneously cleared hepatitis C if you're chronically infected with hep B. If you didn't, you're going to have a lower hep C viral load, nearly a log lower, than if you didn't have chronic hepatitis B. And then, interestingly, despite those somewhat salutary effects, you're going to have more cirrhosis if you have the two together compared to one alone. So these have been known, they're well established, and there's really nothing new happening in that. And what's been more interesting, however, is in that paradigm, in that context of these interrelationships, and they're not just epidemiologic, the point I'm going to try to make today is that there's also collateral immunologic interactions among these, and principally we think immunologic and not antiviral, or not viral, but immunologic. And so there's some homeostasis, some balance that occurs with these interactions. And so it might be anticipated what happens when you take this one off. What happens when you cure hepatitis C to this dynamic? So that's the question. And very soon after the approval of direct-acting agents for eradicating hepatitis C, there were case reports like these, where, for example, to orient you, this is the viral load here on the y-axis, and ALT down here on this y1 axis, and then just the time after beginning anti-HCV therapy. And you can see, as you would predict, you start the medications and the hep C viral load plummets. It plummets really quickly and stays down, and of course this is what we all know about with being cured. ALTs were not that high in the beginning in this instance. What I want to draw your attention to is this person had low-level hepatitis B, as often is the case. This was the dominant virus, not this. But when this one is suppressed or taken off the seesaw, if you will, this one rebounds, and then it has to be treated with tenofovir and emtricitabine. And so here's another case. This one you could say, the clinicians in the room might say, okay, fair enough, but that person had ongoing hepatitis B infection. That kind of makes sense, and they should have known and been more careful. But what about this one? What about this instance where the person has no detectable hepatitis B, is surface antigen negative, only has isolated core? So this is a patient with isolated core, a situation that we really don't think of as being particularly, it's functional cure, if you will, of hepatitis B, if you want to echo back to last evening's discussion. So functional cure, and then you take hepatitis C out of the picture with direct-acting agents, and you have this rebound that occurs that requires treatment. This one was not clinically significant. So these are two cases, and we're sort of the beginning of a series of cases that are now enumerated at 29 as reported to the FDA in the sort of year and few months after the approval of the direct-acting agents. And so when you define a reactivation of hepatitis B as being some abrupt increase, at least a log increase in the hep B replication, but often sometimes, in some instances, clinically significant, they've pulled 29. Interestingly, 19 of the 29, the majority from Japan. There are two patients who have already died. One required transplantation, and 6 required hospitalization. So this ended up becoming a predictable, to some extent predictable, and important complication of this in this co-infection dynamic. Here are the cases themselves, and for the sake of the clinicians that want these details. And I'll just say that interestingly, 16 of these 29, so 16, the majority, were given a PI, and 11 of those were Antiretroviral, which has been used a lot in Japan. So that sort of Japanese Antiretroviral PI constellation, though there's no statistics to this, is interesting to note in the context because of the possibility of direct toxicity of the medication as opposed to what we're seeing with hepatitis B relapse. Interestingly, 4 were surface antigen negative, as the one case I showed you, so there were 3 others like that, and 16 that didn't have any detectable hep B DNA were considered inactive. So this is an area where that's a new development in the field. It's led to the, in September, for the ASLD IDSA guidelines to recommend that everyone be tested. So everybody, before they get hep C treatment, is now supposed to be tested for replicating or dormant functionally cured hepatitis B, and led to the FDA a month later, or a couple weeks later really, to issue this warning and black box warning that appears with some of the medications. And that's essentially what that comes from. Now it's interesting, that same dynamic that I wanted to this idea of collateral immunity, that there's an ongoing, even in these chronic viral infections, I don't think I have to sell this crowd on the fact that there remains immunity. There remains an antiviral state that, though unsuccessful, continues to try to eradicate. You take away the virus, you remove those antiviral measures, and there can be collateral damage in terms of another viral infection that it was restraining. But interestingly, there's been speculation that that's also carried over to an unexpectedly high incidence of liver cancer that has occurred after clearing hepatitis C with these direct-acting agents. So the idea being that perhaps there's immunity that helps also restrain liver cancer development, or at least its spread, and you take away the hepatitis C and all of a sudden the cancer grows faster than expected. And this group that is extremely well known for their experience with liver cancer, with hepatocellular carcinoma, the Barcelona group, first reported this increased rate a year and a half ago at one of the international meetings. Now, there's been 2 others that haven't substantiated it, but I just raise it here as an example of perhaps yet another example of what could be a collateral effect of what is otherwise clearly a beneficial outcome to eradicate hepatitis C infection. So the point being that there's this dynamic between hepatitis C and hepatitis B, and interestingly HIV. You take away the one and the other one can dominate. And actually that was just because one of my kids was home on holiday and I was dying to learn how to make one of those, so I got him to show me how to make that slide. All right, so the question is then why? What's going on? What can we understand? These are clinical observations, and do we have any basic understanding of them? There have been studies to try to investigate the hypothesis that there's a direct viral interaction, right? So with at least the hepatitis viruses, there's the thought that maybe they're both replicating in hepatocytes and sort of competition for scarce resources, and if you take away one, the other one can replicate more abundantly. That thought is challenging both by the mathematics of the probability of both being in the same place at the same time, but also there are some data in cell culture that suggests that, for example, if you have a system where you're stably replicating hepatitis C and you put in medications that, and hepatitis B, and you put in medications like Antiviral or lamivudine that attenuate the hepatitis B, that you have no effect on, in this instance, the percent of cells with hep C replication. The converse experiment was done by the same group where they had, they looked at Hep B replicative intermediates in this instance, and demonstrated that with direct-acting agents, in this case protease inhibitors, that comparing with and without the protease inhibitor, there was no evidence of any difference in the abundance of hepatitis B replicative intermediates in cell culture, and likewise no difference in protein secretion in the cell culture system. So those with and without the control, without the interference of Hep C replication, and no difference in the production of hepatitis B surface antigen. So that's the notion, is that it's not direct antiviral, and more likely has something to do with the fact that, as I mentioned earlier, there remains in tissue an effort in cells and in the surrounding tissues, an effort to control these infections, and if you eradicate one, then that immunity is lost. So, for example, this is a study that Sean Cotalil and Eric Meissner did, looking at the Hep C viral load here, and this is how long after treatment. And in the beginning, they're just looking here at the Hep C viral load, going down nicely as it does, and then IP10 levels in the blood sharply dropping in this study. They also have liver tissue that they collected just before this treatment and then while on treatment. And in the liver tissue, there were marked decreases in expression of IP10 and a number of other interferon-stimulated genes. So once again, the notion is that these were upregulated in a chronic state to eradicate the hepatitis C. You turn it off, and within days, these genes stop being expressed, and there's a net loss of this collateral antiviral activity against Hep B, and the Hep B within weeks can overspread and come out in the liver. So far, I've just been focusing on B and C on the two-dimensional seesaw, but of course HIV is also in play in this, and it's in these triply infected individuals, it's a three-dimensional construct where we also know, even though we can't really get into the particulars of lacking the right models to dissect these interactions, we have the same clinical observations, and therefore believe similar things occur. For example, in this instance, we're using HAART, antiretroviral therapy, as a way of stopping HIV replication and looking at gene expression and levels of hepatitis C in humans chronically infected with both. They do not have hepatitis B, they have C and HIV. And so the study design is something like this. You take an individual and study them, get a large liver biopsy in experimental conditions, and evaluate their blood and levels of hepatitis C. Then, in this instance, we gave them a dose of interferon to study the dynamics of how their viruses responded to that interferon, washed them out, gave them HAART, suppressed them for at least 3 or 4 months, and then did the same thing over again. And what we can see is that, interestingly, for reasons that no one really understands, antiretroviral at first increases the Hep C, change in Hep C viral load, with up being going up and then down being going down compared to baseline. Hep C viral loads go up really a little bit within a few hours of HAART, which is interesting, at least within a few days. But then on average are a bit lower after antiretroviral therapy in a chronically hepatitis C infected individual, and that can correlate with differential expression of ISGs in the liver. So of course, HIV is in well, at least we think, is in completely different cells, but nonetheless, what it's doing in terms of the immunologic milieu in the liver is noticeably different, or at least there are fewer interactions of HIV on hepatocytes. So without being able to really understand these things better from a clinical point of view, I'm really just making the point that we know that co-infection is very common. It has multiple medical implications that we've come to appreciate and that have clinical relevance, so much so that even right now there's a call for screening broadly for hepatitis B in persons that are about to go on direct-acting hepatitis C therapy. Try to give you a little bit of a background so you would understand why that occurs and some insights into the broad biologic basis. So thanks very much for your attention.